invasive angiogram. Finally, if those things point to that. Okay. So basically, we are not going to talk very much about that. That is for interventional cardiologists. But from your point of view, you need to know what to advise the patient about the lifestyle changes and the medications you are going to write on the patient's drug chart, as well as the prescription you are going to give them. So lifestyle changes, smoking cessation, healthy diet, physical activity, healthy weight, and other things, right? Mainly you have to ensure that the patient is taking the correct medicine at the correct time. Smoking cessation, all smoking has to stop. There are various interventions for that. Healthy diet, diet rich in vegetables, fruit, and whole grains. Limit saturation fat and alcohol limit. You have to limit that. And then they say 5 portions of fruits per day, fruit and veg, and less than 5 grams sodium as well. Physical activity, 30 to 60 minutes, that is half to 1 hour. Moderate physical activity on most days. You have to do whenever possible. Ideally, 7 days a week or at least 6, right? Moderate intensity is where you can't sort of complete a sentence while doing it with somebody next to you. Okay. Healthy weight is you have to keep your BMI ideally below 25. Then the diet, again, some of those characteristics, fiber, fruits and vegetables, more than 200 grams per day, and saturated fat content, less than 5 grams of salt, alcohol limitation, that sort of thing there, and avoid sugary drinks. Okay. So the drugs, now we are going to talk about this and then probably finish the lecture. Chronic coronary syndrome, as well as all the both conditions, the secondary prevention medications also, the same doses and things basically, which I thought I'll talk at this point, because the long-term medications of acute coronary syndrome will fall eventually into the chronic coronary syndrome management. Okay, so aspirin and clopidogrel, you have to start and continue for 1 year after acute coronary syndrome. But for chronic coronary syndrome patients, remember, you don't give both, you only give one. So here the important thing here is clopidogrel. If you are aspirin intolerant, then you can't give aspirin and clopidogrel. In chronic coronary syndrome, you give only one of the antiplatelets, not dual antiplatelet therapy. After those essential times are gone, like say somebody's had the acute coronary syndrome, then you have to give them 1, 2, 3, whatever years according to the stenting and the race. But if you just find somebody coming with chronic stable angina, you diagnose for the first time, you suspect it, while awaiting investigation, there's no place ideally to start acute and dual antiplatelet, because dual antiplatelet therapy is a therapy of acute coronary syndrome, so either STEMI or non-ST elevation MI or unstable angina. Okay. So now this is the most important slide for the chronic coronary syndrome stepwise drug initiation. It's basically the standard therapies on the left side. If somebody has high heart rate, if somebody has a low heart rate, somebody has heart LV dysfunction, and whether somebody has low blood pressure, you need the steps, 4 steps, that what are the best choices of the drugs for you to start with. Initially, standard person, you would start with a beta blocker or a calcium channel blocker. In these patients, basically, if the heart rate is high, you would want to give non-dihydropyridine, that is the heart rate lowering calcium channel blockers like verapamil or diltiazem. If the heart rate is low, then you want to start a dihydropyridine, which is not a rate lowering one, something like amlodipine or nifedipine, is long acting only. And then if somebody has LV dysfunction or heart failure, you would want to start one of those 3 heart failure, 4 heart failure beta blockers, which we mentioned: carvedilol, bisoprolol, metoprolol, or nebuvolol. And if they have very low blood pressure, then you can't start beta blocker or low dose those things. You can either start on one of those low dose, one of those things, or basically switch to this drug called ivabradine, which is just a rate reduction at sinus node only with no blood pressure lowering. Okay, so the second step is basically standard therapy. If they are not controlled on either a beta blocker or a calcium channel blocker, then you have to start add beta blocker and the calcium channel blocker. So to add to a beta blocker, you can't add the non-dihydropyridine calcium channel blocker because both will cause heart rate to drastically low and they will go into sick sinus syndrome and shock and complete heart block. So if you're adding a beta blocker to a calcium channel blocker, it has to be a dihydropyridine. That is like amlodipine and bisoprolol, not verapamil and bisoprolol, not diltiazem and bisoprolol. Okay, so this group also same. If the heart rate is high, you can add a beta blocker to a CCB. But here, although they mention CCB, it's usually when you add it is a dihydropyridine. But if your heart rate is very high, you can carefully add a non-dihydropyridine also at that point. Then LAN stand to long-acting nitrates. If you're at that point, you can add a long-acting nitrate if your heart rate is on the low side, or if you are having heart failure, you can add ivermectin for heart failure sake as well. Ivermectin is licensed for heart failure as well as for angina controls. Both it has shown. Then third line, basically you can in this case add second line drug or long-acting nitrates. And at this point, fourth level, you can add nicorandil, ranelazine, or trimetazine. All these are available. Nicorandil is a potassium channel opener. Ranelazine and other trimetazine endothelial actions. Now, if they are not responding at that point, you want to send them for a intervention, for re-intervention. Okay. So in addition to those particular, now we mentioned aspirin, then we mentioned the anti-angina drugs, and now we mentioned the statins as well as ACE inhibitors. They are also indicated, right? Now, just a few slides, you can look at this later, the doses and the drugs and the remarks, whether they are low cost, they can. Now, interestingly, nebuvolol can cause headache because it has the nitrous oxide donor action as well. So can cause headaches if you add with especially long-acting nitrates, or if you add this with amlodipine, which is also vasodilating action. So, some of these dihydropyridine calcium channel blockers can cause ankle edema in our country. The non-dihydropyridine 1 and 2 should not be added with beta blockers. Nifedipine has to be given long-acting. If you are going to give the normal one, then it can cause higher mortality. Okay. So the aspirin doses, clopidogrel, prasugrel, and ticagrelor. Now, some of these newer P2I12 inhibitors, lot of contraindications. You cannot give in elderly people if they have had CNS bleeds, CKD. So you have to be careful. What is available in the hospital is clopidogrel. That is also not available these days. So if we can give aspirin and clopidogrel long term, that is probably the best option for this innovation. And clopidogrel also at 75. One of those, right? Unless both. So statins, lipid lowering, atorvastatin, several statins are there. We can, what is commonly used, atorvastatin, rosuvastatin. Atorvastatin high doses, basically 40 and 80, usually given at night. You can also add basically ezetimibe if you can't achieve alone with the statin, especially if you get myopathy and your CK levels go up. Then antiangents, we have gone through the long-acting nitrates, sublingual GTN spray when if they are anticipating angina, nicorandil potassium opener, ivermectin, that is cyanide IF receptor blocker, and can give also in heart failure, and ranelazine can cause actually QT prolongation. Better to avoid if there is QT prolongation and in heart failure. Okay, so basically hypertension, we mentioned the blood pressure targets 140 by 90, and then diabetes. Diabetes, if you have ischemic heart disease and diabetes, there are 3 or 4 drugs which have been proven to benefit. Number one is metformin, which is shown to be beneficial. Then also this what are called sodium glucose transporter inhibitors, empagliflozin, canagliflozin, dapagliflozin. All three are available in Sri Lanka, and I think rather empagliflozin, dapagliflozin. Empagliflozin 10 milligrams a day supposed to reduce mortality by about 30-40% in some of the trials in acute coronary syndromes as well as ischemic heart disease. So you need to give that if possible, but very, very costly. Each tablet is about 100 rupees. So number 3 is basically these other things like glucagon-like peptide, but these are not oral drugs and not available. Some of them I think not available here as well. And then the other one is the glitazones, pioglitazone has also proven beneficial in reducing cardiovascular disease. But pioglitazone causes fluid retention and can exacerbate heart failure. So metformin is a good choice, although it is not mentioned here. But they are emphasizing on empagliflozin for diabetic patients, if that is possibly given, can be given. And also ACE inhibitors, trials have shown in chronic coronary syndrome patients with diabetes, it benefits, right? Class 1 indications and good trials. Okay, so what are the lipid targets? Where basically patients, when they develop coronary artery disease, documented atherosclerotic cardiovascular disease fall into a group called very high risk. There are 3 other groups, high risk, moderate and low risk. But for these people, the cutoff limits are basically 55, and you have to, here the red color basically says you have to start drugs immediately. Say if you are low risk, if your LDL is 190, you have to start more than 190, start drugs immediately. Anybody below that, you can basically play on, give lifestyle advice, repeat and see, that sort of thing, right? But for the very high risk group, right, if it is less than 70, you start the drugs and bring it to less than 55. If it is less than 55, you continue what you are giving, right? Along with lifestyle. And basically the lifestyle modifications we mentioned earlier: smoking, healthy diet, physical activity, weight, and those things. Diet also we mentioned. So basically, I think just we are going to finish now. The risk stratification. Now, the important thing is when you managing chronic coronary syndrome patient, you have to reassess ever so often. And if the symptoms deteriorate, or if you think they need an invasive coronary angiogram, then you have to send them for that, right? So basically, how do you do that? You have to do echocardiograms often, probably about a year or so, and do probably exercise ECG. And if those point towards worsening or the chronic coronary syndrome getting bad, then you have to send for an invasive angiogram. Now let's quickly look at the 2 MCQs and stop at this point. You can switch on your speakers and ask questions, or basically give some responses, or write at the bottom of the screen or whatever. The answer I have basically considered here is the top one, because in the ICU setting, this is a non-ST elevation MI. So you have to start dual antiplatelet loading and enoxaparin. In addition to that, even number B, you can start high dose statin at that point, but or even IV morphine if the patient is in continuous pain. But the point I considered is that the blood pressure is a bit on the high side, 160/100, and therefore at this point you need to get it lowered. You might want to try sublingual GTN spray and the pressure to come down, but for anti-anginal effect as well, and to bring the blood pressure down in intravenous GTN infusion in the ICU, and titrate the dose so that the coronary arteries also get a bit dilated, and the blood pressure also preload, afterload reduction. So the importance of giving infusion of GTN, which I didn't mention in the lecture, but in this scenario of very high blood pressure. Okay, number 2. Now this guy is basically diabetic, hypertensive smoker. It's a chronic coronary syndrome scenario with no acute problem at the moment. And what would you give at this point? Number A, first one, would you give dual antiplatelet to this guy? If anyone can answer that? Yes or no? Well, I think there's no indication for giving. Oh, there are 75 participants, excluding me 74. Right. Okay. So dual antiplatelet, no. Only either aspirin. If aspirin is not tolerated, only clopidogrel. So A is out. Then basically statin you have to give. Then the first choice is either this dihydropyridine calcium channel blocker. You can give, but best option would be to give a non-dihydropyridine calcium channel blocker. But here the problem is you add non-dihydropyridine with beta blockers and also long-acting nitrate beta blocker. Those combinations are good. Beta blocker ivermectin is also good because the heart rate is 90. But I would probably go for in this patient the third one as a metformin because we mentioned in diabetics you can give that. So I would probably go for this patient falls at this point. So we'll probably go for. Oh, sorry, it's wrong. It should the second response should read non-dihydropyridine one, or you can actually you can actually go for a beta blocker at this point. So I would probably go for number one here, which is high heart rate beta blocker plus statin plus dual. Sorry, this is wrong because it's not DAPT. I think there's a mistake here. It will be number two with non-dihydropyridine calcium channel blockers. I'll correct it when I'm posting it on the anyway, I think you have got the hang of it. Basically, it's important to realize these other parameters as well when you are going for the for these deciding on your drugs. Okay. So hopefully that gave you a bit of a understanding about these things. And are there any questions? The presentation as well. Is the batch monitor there?
Yes, sir.
What is your name? Hello?
I'm Ravin, sir.
Okay. Did you follow the lecture? Was it good?
Yes, sir. Thank you, sir.
Too fast? You can understand.
Sorry, sir.
You can go through it in leisure and see, right? If there are any questions.